What is going on, lovely people? This is Medicosis Perfectionalis, where medicine makes perfect sense. Today we'll talk about cholecystitis. What does the word chole mean? Chole is referring to the liver or the biliary system. Why chole? Like, why this word and not other? Do you remember cholesterol? Yeah. Why do you think we call it cholesterol? Because it comes from the liver, the chole. Cholesterol, chole, liver, sterol, because it's a steroid. It's fat. Next, we have the word cyst. Okay, cholecyst. What's the cholecyst? All right, something related to the liver or the biliary system that is a sac. And this is the gallbladder. Cholecyst, gallbladder. Itis is inflammation. What are the cardinal signs of inflammation? Redness, hotness, swelling, pain, loss of function. Do you think we'll see fever here? Yep, we can see fever in cholecystitis. Do you think the patient will feel pain? Absolutely. But where will the patient feel the pain? Right hypochondrium, because this is where the liver and gallbladder are, or right upper quadrant? Most of the time, not all the time. Imagine a patient with low-lying gallbladder. Then the pain can be here, right lumbar, or even here, right iliac. So it's possible to have pain in the right lower quadrant in cases of cholecystitis. Moreover, what if the patient has situs inversus totalis? Oh, this patient's viscera are reversed. They are flipped. The liver is on the left, the heart is on the right, the spleen is on the right, everything is flipped. In this case, the pain will be in the left upper quadrant. Oh, by the way, this video is brought to you by Grace. Thank you so much, Grace, for supporting my channel. And please, guys, take 5 seconds to say thank you to Grace in the comment section. This is part of my playlist called Hepatology. Now let's start with the basics. Ever wondered why the pain of cholecystitis can radiate to the right shoulder? I'm gonna tell you. Do you remember the phrenic nerve? Yeah, where does it come from? C3, 4, and 5. Here in the neck. And it goes down, 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 and it supplies the gallbladder. Awesome. Do you remember the brachial plexus? Yup. It starts from C5 and ends at T1, so it starts here. And then it supplies the shoulder and the upper extremity. Have you noticed that C5 is common among the two? Yeah. C5 root supplies the shoulder and the gallbladder? Yeah. The gallbladder pain is a visceral pain. It's poorly localized. It goes to your spinal cord here. But the brain cannot tell the difference because it's vague and poorly localized. So the brain will project it forwards here. And since this is C5 segment, you can also project it to the shoulder. So the brain will project it to the gallbladder. That's why you have right upper quadrant pain. And the brain can also project it to the right shoulder blade. Put differently, what people call referred pain is nothing more than a viscerosensory reflex. But what if the visceral sensory limb gave the impulse to the central nervous system and then the central nervous system decided to project this here with the anterior or motor branch? What would you get now? I'll get a visceromotor reflex, what people call guarding and rigidity. These two are reflexes, something that your woke professor will never tell you. Also, this is one of the ways to tell if the patient is faking the pain or if the pain is real. If you see guarding and rigidity, it is a reflex. The patient cannot fake a reflex. The anatomy of it. Here's your lovely liver. The liver secretes what? Bile. Alright, the right hepatic lobe is going to secrete the bile into the right hepatic duct. The left hepatic lobe is going to secrete it into the left hepatic duct. Now bile is here. Right hepatic duct and left hepatic duct will meet in the middle, and now it's called the common hepatic duct. Alright, let's stop here. Let's go to the gallbladder. The gallbladder is beautiful. It has a cystic duct, and this cystic duct is going to join the common hepatic duct, and they will form a common bile duct, or CBD. Although Joe Rogan might have a different interpretation of this word. The common bile duct is also the choledocho. So when I say choledocholithiasis, it means a stone in the choledocho. What's the choledocho? The common bile duct. Where does the common bile duct go? It goes here, right? And then it joins the pancreatic duct. Together they will open into the duodenum. Be specific. They will open into the second part of the duodenum. Be more specific. They will open into the posteromedial aspect of the second part of the duodenum. In this area, there is a sphincter known as the sphincter of Oddii. But Why did the common bile duct and the pancreatic duct join each other? Glad you asked, because this has to do with physiology. Fat absorption. When you eat a fatty meal, you will need 3 organs just to absorb this fat. First organ is the liver and the biliary system. Second organ is the pancreas. Third organ is the gut, the intestine, which will actually absorb the fat from the intestine to the bloodstream. So why do I need the intestine? Because it provides the surface for absorption. Why do I need the pancreas? Because it secretes lipase and colipase, phospholipase, all kinds of lipases to digest lipids. Why do I need the gallbladder? Because the bile can help me digest fat. All right. Is there a hormone that is secreted from the gut and goes to the gallbladder to tell her to squeeze that bile out, to contract herself and get the bile out to the gut? Yes, it's called cholecystokinin. I love the word. What does kinin mean? If it ends in in, it's usually a protein. So it's a protein that has kinetic action. Kinetic movement. Movement of what? Of the gallbladder. Cholecyst. Cholecystokinin. I'm the hormone that moves the cholecyst. I'm the hormone that contracts the gallbladder. Isn't that beautiful? The bilirubin story. What is bilirubin? Bilirubin is trash. Bilirubin is a bunch of debris. Debris of what? Of the red blood cells. When the red blood cells get old, older than 120 days, it's time for them to die. Who kills them? The reticuloendothelial system, such as the spleen, macrophages, etc. Inside this red blood cell, what do you find? You find the hemoglobin. Hemoglobin is made of heme and globin. Globin is just a bunch of amino acids. We will recycle them. No big deal. But heme is a big deal because heme is made of iron and protoporphyrin. So when you digest the heme, we get iron and protoporphyrin. And then protoporphyrin becomes biliverdin. If you ever do fresh dissection on a cadaver, you will see that the bile duct, the biliary tree, and the duodenum are stained green. Where did they get the green from? From biliverdin. Verd means green in French. This biliverdin will be reduced into bilirubin. This bilirubin came from the heme, so we call it heme bilirubin. This bilirubin is fat soluble, water insoluble. If it's water insoluble, I cannot send it to the kidney for excretion. Even though it's trash, I gotta wait because it's fat soluble, water insoluble, therefore the kidney cannot handle it. You can't handle the truth. You can't handle the fat soluble. For the kidney to get rid of you, you have to be water soluble. Alright folks, so in order for us to get rid of this bilirubin in the kidney, we gotta convert it from fat soluble to water soluble. And how do you do this? It's called conjugation, baby. Who does this? The liver. Which enzyme? UDP glucuronidase transferase. My goodness. Now the bilirubin will change from fat soluble to water soluble, from unconjugated bilirubin into conjugated bilirubin, from heme bilirubin that belongs to the blood into cholebilirubin that belongs to the bile. Beautiful. How can we differentiate between the unconjugated bilirubin and the conjugated bilirubin in the lab? It's called the Vandenberg test. They found that this unconjugated bilirubin reacts indirectly with the reagent. So we called the unconjugated bilirubin indirect bilirubin because it reacts indirectly with the reagent in the Vandenberg test. However, when we did the same test with the conjugated bilirubin after conjugation, after passing through the liver, this bilirubin gave us a direct reaction with the reagent, so we called the cholebilirubin, the conjugated bilirubin, direct bilirubin. So now we have two types of bilirubin, unconjugated and conjugated. The unconjugated is the heme, it's also the indirect. The conjugated is the chole or the direct bilirubin. Why did you do all of this? Why did you conjugate it? Because I made it water soluble. Now I can send it to the poop or send it to the kidney to excrete it in the urine. Go to hell because you are waste. You are waste products of the red blood cells. Question: why do people get jaundice? 3 reasons. Reason number 1, too much red blood cell destruction. Oh, lots of hemolysis, lots of bilirubin in the blood. And the liver cannot keep up with all of this demand. So you will get jaundice. Jaundice is elevated total bilirubin in the blood. Anything that increases the total bilirubin will make you yellow, like SpongeBob. Reason number 2, Your liver has failed. You have cirrhosis. Oh, if I have cirrhosis, I will not be able to conjugate the unconjugated into conjugated bilirubin. Therefore, what's going to happen? Bilirubin is going to increase in the blood. When you have high bilirubin in the blood, you get jaundice. But which bilirubin will increase when I have cirrhosis? The unconjugated and the conjugated. How come? The unconjugated is easy because the liver could not conjugate it. But how come the conjugated also increases in the blood? Here's the deal. Your liver is toast, but some very few cells are still functioning, so they conjugate some of the bilirubin. But they cannot excrete it into the duodenum because of all of this fibrosis. So it will have to leak to the blood. When it leaks to the blood, you have elevated levels of conjugated bilirubin. Awesome. Reason number 3 why people get jaundice. Obstruction. Obstruction from where to where? From the liver to the gut. Oh, obstruction here. Yeah. Now what's going to happen? What's going to happen is after you conjugated your bilirubin, you will not be able to excrete it to the duodenum. You will not be able to excrete it in the urine or in the stool. Therefore, it will have to leak to the blood. Too much bilirubin in my blood, I become yellow. It's called jaundice. So the question is, does cholecystitis have jaundice? The answer is usually no. Why not? Because it depends on the site of the stone impaction. Okay, tell me about it. Let's say that we have a stone here. Does this obstruct the flow of bilirubin from the liver to the gut? The answer is no. Bilirubin is going to go from here, down here to the gut. This stone is not going to affect the bilirubin, therefore this stone will not cause jaundice. Okay. Let's say now that the stone is here in the cystic duct. Does this stone obstruct the flow of the bilirubin from the liver to the gut? The answer is still no. So, no jaundice in cholecystitis. But if the stone is pushed here, does this obstruct the flow of bile from the liver to the duodenum? The answer is yes. This is an obstructive jaundice. Does it cause jaundice? Absolutely. So it really depends on the site of the stone. That's why most of the cases of cholecystitis have no jaundice, because the stone is in the cystic duct and not in the common hepatic duct or the common bile duct. What are the components of the bile, which is in the biliary tree and in the gallbladder? We have good stuff, such as bile acids and bile salts, and we have bad stuff, the waste products, the conjugated bilirubin. The good stuff is important and we should recycle it, and that's why we have an enterohepatic circulation between the intestine and the liver. Enterohepatic. Okay, how about the waste product? No, I don't want it back. Throw it in the trash. How do you do this? Send it to the stool, stercobilinogen and then stercobilin. Send it to the urine, urobilinogen and urobilin. What are the types of gallstones inside the gallbladder? We have pigmented stones and we have non-pigmented stones. Okay, the pigmented stones are black or brown. Black is usually calcium bilirubinate. Brown is made of bilirubin. Why do you get black stones? Hemolysis. Why does a baby with thalassemia get black stool? Also hemolysis. It's caused by the destruction of the heme. How about brown stones? Bilirubin, and they are caused by infections. Usually more common in the Asian population. Are these pigmented stones the most common? Nope. The most common stones are the non-pigmented yellow stones. Why are they yellow? Because of cholesterol. Who made this cholesterol? The liver. That's why it's called cholesterol. It's a steroid made by the by the liver. Okay. Examples include cholecystitis, biliary colic, etc. So cholecystitis, what kind of stone do we see? Yellow stones. Cholesterol stones. Non-pigmented stones. If the patient suffers from cholecystitis, where is the stone stuck? It is stuck in the cystic duct. Other stones are mixed. They have some of this plus some of this together in a combo. So they have cholesterol and calcium bilirubinate and calcium carbonate. Here is a rule of thumb. If a stone has calcium carbonate, it's going to be radio opaque and you can see it on X-ray. But most of these stones are radiolucent, which means you cannot see them on X-ray. What should I do? Ultrasound. Bile acids and bile salts are the good stuff. Why good stuff? They are water soluble. That's amazing. And they make cholesterol soluble in the bile because the bile is watery. Yeah, so I make the cholesterol soluble in the water. How about phospholipid? Phospholipid is also part of the bile, such as what? Lecithin. Do you remember the surfactant? Yeah, it was made of lecithin. Lecithin is fat bound to phosphate. Alright, is fat water soluble? Heck no, it's water insoluble. And that's why you need the phospho part of it, because phosphate is water soluble, and this lecithin is going to help the cholesterol be soluble in the bile. In other words, if you have robust bile acids, bile salts, and enough phospholipids, you will not have cholesterol precipitation in form of stones, because now cholesterol is kept soluble in the bile thanks to bile acid, bile salts, and lecithin. But if for some reason you have problems with your bile acids, bile salts, or phospholipids, this cholesterol will become insoluble in the bile. It will start to precipitate, forming cholesterol stones. If this stone gets stuck in the cystic duct, welcome to the painful, feverish land of cholecystitis. Risk factors: a horrible mnemonic, fat, fertile female in her 40s. And if this was not horrible enough, consider this: fat, fabulous, fertile female in her 40s with fever and 45 freaking kids. Why is she fabulous? First of all, because she's the mother of 45 freaking kids. She's fertile and she has too much estrogen. That's a fabulous female. Shut up, medicosis. Tell me, why is estrogen problematic here? Well, estrogen is not problematic. Too much estrogen can be problematic. How do I end up with stone in my cystic duct? Alright, you have problems with your bile acids, bile salts, or problems with the lecithin. And therefore, cholesterol is not made soluble in the bile. Cholesterol is gonna precipitate because it's insoluble. And it will supersaturate. And you will end up with cholesterol gallstones. Gallstones in the gallbladder can lead to biliary colic. When they get stuck in the cystic duct, you get cholecystitis. Cholesterol synthesis pathway, do you remember? Yeah, citrate. Where do you get it from? Mitochondria, remember? It was called the citric acid cycle, or Krebs cycle, or TCA cycle. Citrate into acetyl-CoA, all of this happened in the liver, by the way. By an HMG-CoA synthase, you get HMG-CoA. By HMG-CoA reductase, you reduce the HMG-CoA into mevalonate or mevalonic acid, and then farnesyl whatever, and then scalene. By scalene epoxidase, you get scalene epoxide, and then you get cholesterol in the liver. This is called de novo cholesterol synthesis. Notice that estrogen stimulates the HMG-CoA reductase. With estrogen, you will have more cholesterol. More cholesterol equals more risk of cholesterol gallstones. See, medicine makes so much sense once you understand what the flip you're talking about. That's why this disease is common in females. But why is it common in old people, like females in their 40s, especially after age 40? It's also common in old males. What's the problem with old age? Well, as you get old, your life turns into a country song. Cholesterol is not capable of becoming soluble anymore. It starts to precipitate more. You get more gallstones. About a quarter of old people have stones in their gallbladder. Let's talk about lipoproteins. Lipoproteins, lipid and proteins. Cholesterol, is it fat or is it water? It is fat. It's water insoluble. Therefore, it cannot float freely in the blood because the blood is water, called plasma. Therefore, someone has to carry this cholesterol in the blood because cholesterol is fat and the blood is water. Fat cannot float in water. Who is this taxi that's going to carry cholesterol in the plasma? Lipoproteins. Because they are covered in proteins and proteins are water soluble. Oh, so we are fooling the plasma. That's right. What are these lipoproteins? They have lipids and proteins, and they have many subtypes, including chylomicrons, VLDL, LDL, HDL. As you go from here to here, the amount of fat is decreasing, but the amount of protein increases. What's the job of HDL, the high-density lipoprotein? High density of what? Of protein, not of fat, of protein. It's high density compared to this, compared to this. Tell me the function of the HDL. I transport cholesterol from the peripheral tissue back to the liver. Awesome. How about LDL? How do you get LDL back to the liver? You need an LDL receptor. When LDL binds to the LDL receptor, the liver will take it back. Pathogenesis of cholecystitis. Number 1, you have problems with your bile acids, bile salts, and with lecithin. That's why your cholesterol is less soluble in the bile. Cholesterol becomes insoluble, precipitates, supersaturates, becomes cholesterol gallstones. This is number 1. Number 2, if you have bile stasis, let's say your gallbladder is weak, biliary dyskinesia. Let's say you have too much sludge. There is too much stasis. This will increase release of inflammatory enzymes, such as phospholipase A2. Phospholipase, I love this word. What does phospholipase do? It breaks down phospholipids. Like lecithin? Yeah, like lecithin. And when you destroy lecithin, what it becomes? Lysolecithin. Lecithin after lysis. I love it. Why is this bad? It's bad for two reasons. Number one, when you convert your lecithin into lysolecithin, the amount of lecithin will decrease. Therefore, you cannot make the cholesterol soluble in the bile and you get stones. Moreover, when you become lysolecithin, this is a pro-inflammatory SOB. Inflammation equals itis, called cholecystitis. You have cholesterol gallstones, it's going to obstruct the cystic duct, causing inflammation and damage of the mucosa of the gallbladder and the cystic duct, which will secrete fluid. Fluid distends the gallbladder. The gallbladder gets ischemic because the gallbladder is too big and the blood supply is not enough, because the blood supply is made for a normal gallbladder, not for an obese gallbladder. Alright, so the blood cannot keep up, I get ischemia. When I get ischemia, I get more mucosal damage. When I get damage, I get more fluid secretion and inflammation, more gallbladder distension, more ischemia, more inflammation, and you get into a nasty, vicious circle. The gallbladder distension releases prostaglandins. Prostaglandins cause inflammation, and you continue. The stone is in the cystic duct. The gallbladder is contracting, bile is not flowing. I'm contracting, bile is not flowing because the stone is obstructing me. So, as a result, the wall of the gallbladder will get even thicker. Similarly, if I have aortic valve stenosis, what do I get? Left ventricular hypertrophy. Same freaking concept. Next, estrogen increases my risk of gallstones. How come? By three mechanisms. Let's go. Number one, it increases HDL synthesis. HDL transports cholesterol from the peripheral tissue to the liver. Now there is too much cholesterol going to the liver. More cholesterol in the liver, more cholesterol in the bile, more risk of cholesterol gallstones. Estrogen increases LDL uptake by the liver. Remember the LDL receptor? Yeah, now it's going to take more LDL into the liver. What's in the LDL? Fat, cholesterol. More cholesterol gallstones. Third, estrogen increases the activity of HMG-CoA reductase enzyme, making more cholesterol. More cholesterol, more stones. Do you remember my video on the Donan equilibrium? Yeah. Can you summarize physiology in one word? Yeah, homeostasis. Can you summarize pathology in one word? Lack of homeostasis. Can you summarize internal medicine in one word? It's called hypoperfusion. Hypoperfusion to the heart, you get stable angina, unstable angina, non-STEMI, or God help you, STEMI. Hypoperfusion to the brain gives you TIA or a stroke. Hypoperfusion to the kidney, pre-renal azotemia, which is an acute renal failure. Hypoperfusion to the lungs, you get red infarction. Hypoperfusion to the gut, you get ischemic colitis and mesenteric ischemia. Hypoperfusion to your hands, you get Raynaud's phenomenon. Hypoperfusion to the liver, ischemic hepatitis. Hypoperfusion to the gallbladder, acalculous cholecystitis, inflammation of the gallbladder without stones. In other words, cholecystitis is caused by stones most of the time, but not all the time. You can still get acalculous cholecystitis due to ischemia, hypoperfusion, especially if I have shock or severe extracellular fluid volume depletion. By the way, you know where the word calculus came from? It came from stone. Calculus literally means a stone. And in math, we have calculus. Why calculus? Why do they call it calculus? Because Isaac Newton was trying to find the smallest piece and he found a small stone or a small rock. So he called the science calculus. Yeah, it's a true story. You can also get calculus in your mouth and you go to the dentist for that. You can get kidney stones. You can get all kinds of stones. Stones are everywhere. What else? Neoplasms, bile duct strictures. Immunocompromised patients can get cholecystitis due to CMV, which is a virus, or cryptosporidium, which is a parasite. In summary, cholecystitis is caused by stones most of the time, but not all the time. Stages of cholecystitis. Let's do this. Stage 1, 2, 3, and 4. 1. Contraction. 2. Impaction. Of what? Of the stone. 3. Bacterial invasion. 4. Perforation. Stage 1. You eat a fatty meal. The gallbladder is going to contract. Thank you, CCK. If the gallbladder has a stone, the stone will be pushed until it reaches the cystic duct. This is when the patient first felt pain. It starts mid-epigastric and is colicky until the stone gets impacted in the cystic duct. I'm stuck in the cystic duct. Accumulation of mucus behind the obstruction happens. Chemical irritation, bacterial overgrowth. What kind of bacteria? All kinds of bacteria, such as E. coli, Enterococcus, B. fragilis, Clostridium species. If you're immunocompromised, you get a virus such as CMV or a parasite such as Cryptosporidium. And this is where the patient went from mid-epigastric into right upper quadrant pain. It might radiate to the shoulder. Remember, referred pain is a viscerosensory reflex. Stage number 3 is bacterial invasion. I'm invading the gallbladder. Oh, after you invade the gallbladder and get out of the gallbladder, what do you find? Peritoneum, localized peritonitis. You might see a rebound tenderness here. And this is where the nurse or the doctor elicited a positive Murphy sign. If it's bacterial invasion, if I do a blood test, what would I find? Leukocytosis. Which white blood cell is responsible for fighting bacteria? Neutrophils. Stage number 4 is perforation. That's horrible. Perforation of the gallbladder. Boom! Peritonitis, inflammation of the peritoneum. You get what? You get rebound tenderness, guarding, and rigidity. Visceromotor reflex. And you can get a fistula between the gallbladder and the intestine. What do you call a fistula between a gallbladder and the intestine? Cholecystoenteric fistula. Love it. Enteric, small intestine. Cholecysto, gallbladder. And now the stone can leave the gallbladder through the fistula. You can end up with a stone in your small bowel, and we call this gallstone ileus when it obstructs the small bowel. Risk factors for cholecystitis. Fat, fertile female in her 40s with fever and right upper quadrant pain. Why fat? Because if I'm an obese person, I'm literally full of fat, cholesterol. Also, in general, obese people eat lots of fat. More fatty meals, more cholesterol, and the gallbladder is responsible for secreting the bile to digest the fat that you ate. The more you eat, the more the bladder is going to contract, and the more likely that you will have cholesterol gallstones. Cholesterol gallstones and the bladder is contracting, the stone can get stuck in the cystic duct. Welcome to cholecystitis. Fertile female, why? Estrogen and progesterone, they are steroidal hormones. They are literally made of cholesterol. Moreover, estrogen can increase my risk of cholesterol gallstones by 3 mechanisms that we have discussed before. Why in your 40s or older? Because the older you get, the slower your gallbladder contracts. You get more stasis. Stasis, bacteria. Bacteria, inflammation, ischemia, all kinds of stuff. These are the most important risk factors. Other risk factors, we will divide them into genetic and environmental. Genetic, female over 40, Native Americans, especially from certain tribes such as the Navajo or the Pima. Obesity, environmental, obesity, especially when you eat too much fat. Rapid weight loss. You know why? Because you're eating too little fat. You're not eating enough fat, okay? And here's your gallbladder storing all of this bile for you. But you're not eating fat. Hey, dude, why don't you eat fat so that I can contract and give you my bile? I'm not eating fat. You're not eating fat? Eventually, the gallbladder will get sick and tired of being sick and tired and will say, take this, Jeffrey, and will pump all of that bile out. Oops, but there was a stone here. Welcome to cholecystitis. So, too much fat is bad. Too little fat can also be bad. Absorb this before you listen to your health gurus. Oral contraceptive pills. Why? They have estrogen and progesterone. Estrogen and progesterone are steroid hormones. Weight loss medications for the same reason. These weight loss medications make you lose your appetite. A beautiful story that's gonna make your gut turn, no pun intended. William Shakespeare wrote Macbeth. Charles Dickens wrote A Tale of Two Cities. Medicosis is gonna write A Tale of One Cholelith. Doesn't that sound like Old English? Subtitle, The Story of the Stone. Tell me about the story of the stone. When you have stones in your gallbladder, this is called cholelithiasis. When the same stone gets stuck in the cystic duct, it's cholecystitis. If this lovely stone obstructs the common bile duct, you will have choledocholithiasis. If it's really too bad and you're too old and too sick with hypotension and altered mental status, it's called ascending cholangitis. Chol means bile. Angio means vessel, bile vessel. Itis, inflammation, inflammation of bile vessels. The same freaking stone went and obstructed the pancreatic duct at the head of the pancreas. This is called gallstone pancreatitis or biliary pancreatitis. At the end of the day, you have a fistula between the gallbladder and the intestine called cholecystoenteric fistula. Now the stone is going to end up in your ileum, eventually obstructing it, called gallstone ileus. which is a mechanical obstruction of the small bowel. This was medicosis at his best. And as college students might say, if you don't support me at my worst, you don't deserve me at my best. What if I have contraction of the gallbladder and it's painful, especially after I eat a fatty meal? The pain lasts for like 30 minutes or something. This is just biliary colic. What if my bladder doesn't contract properly? It's very slow. Biliary dyskinesia. What if I have too many stones in the gallbladder? Cholelithiasis. What if the stone obstructs the cystic duct? Cholecystitis. What if I have all of these symptoms without a stone? A calculus cholecystitis, especially with hypoperfusion. Happens a lot in the ICU when the patient is very sick. The stone is in the common bile duct, choledocholithiasis. In choledocholithiasis, you have a triad called the Charcot's triad. Fever, right upper quadrant pain, and jaundice. Alright, if the patient is super duper sick, and you have the 3 symptoms plus 2 other symptoms, hypotension or any hemodynamic instability, plus altered mental status. This is called Raynaud's pentad, and the diagnosis becomes ascending cholangitis. That's an emergency situation. You will need emergent intervention. You will call the surgeon. You will wake him up from his comfortable, air-conditioned home in the suburbs. Even if he's sleeping and dreaming of Lady Gaga, wake him up. Come here, doofus. You need to intervene right now. The stone is at the head of the pancreas, gallstone pancreatitis. The stone is in the small intestine obstructing it, gallstone ileus. It only happens after a fistula. The gallstone is evil. It can cause inflammation. It can obstruct. You get cholecystitis, cholangitis, anything that ends in itis, pancreatitis. You get choledocholithiasis, biliary pancreatitis, gallstone ileus. The stone can perforate, causing peritonitis or a fistula between the gallbladder or any surrounding structure, such as the intestine. The stone can go places like a Toyota Corolla. It can go to the cystic duct, common bile duct, pancreatic duct, peritoneum, or intestine. This is called cholecystitis, choledocholithiasis, gallstone pancreatitis, gallstone ileus, peritonitis. Lots of gallstones for a very long period of time. If you have genetic underpinnings, you can increase your risk of cancer. Clinical picture of cholecystitis. What's the difference between the word sign and the word symptom? Easy. Sign, I, as a doctor or a nurse, will find it out. But symptom, you, the patient, will tell me what's up. So pain is a symptom. Tenderness is a sign. Fever, right upper quadrant pain, or right-sided chest pain, or in some cases a right lower quadrant pain if it's a low-lying gallbladder. This pain can be very severe, like angina pectoris, but without the sense of impending doom. Unlike angina pectoris, this pain lasts for 6 hours. What if the pain lasts for like 30 minutes? Happens only after fatty meals. This is biliary colic and not cholecystitis. The pain of cholecystitis can be associated with nausea, vomiting, and low-grade fever. What if it's a high-grade fever with lots of cough and signs of consolidation? No, it's going to be right lobe pneumonia here. Not just pain, but also tenderness. Right shoulder pain. This is the referred pain. It's a viscerosensory reflex. Right upper quadrant guarding and rigidity are rare. They are signs of peritonitis, visceromotor reflex. A positive Murphy sign when you do it with your hands. A positive ultrasonographic Murphy sign when you do it with the ultrasound probe. Nausea, vomiting can happen. Palpable gallbladder, you might be able to feel it. Is there jaundice? Usually not. If you see jaundice, it means the stone has left the cystic duct. The stone is now in the common bile duct or the hepatic duct. How do we do Murphy sign? Listen carefully because most people do it wrong. Because most of them do it with the right hand when in fact you should do it with your left hand. Does that make any difference? Shut up. Of course it does. So here's your patient lying down, supine, on the exam table. You stand on the right side of the patient. Use your left hand. Lay it down on the patient's lower right chest so that your fingers are aligned with the last ribs so that your left index finger is on top of the last rib. You mean the 12th rib? Shut up, the 12th rib is behind. It's a floating rib. No, it's not the 12th rib. This is the right 10th rib. Now your thumb is below the right lower ribs. And then you will do something crazy. You will start to abduct your thumb and then oppose it rotate it downwards as if you're doing a thumbs down sign. Underneath your finger in this area is the gallbladder. Press on that gallbladder. Ask a patient to take a deep breath. The patient will initiate the inspiration. More pain is going to happen. The pain will reach its peak at mid-inspiration to the point that the patient will stop inhaling at mid-inspiration. Oh, it hurts! You can do it again with a different procedure, a placebo maneuver. So basically, without pressing your thumb, ask the patient to inhale. The patient will inhale. Yeah, there will be some pain and discomfort, but the patient will be able to continue and complete the inspiration. When both scenarios happen, this is a positive Murphy sign. A positive Murphy sign is when your patient moans and stops at mid-inspiration. Differential diagnosis of right upper quadrant pain. This is just a quick summary. Acute cholecystitis and related conditions. Biliary colic, cholangitis, choledocholithiasis, all kinds of stuff. Pleurisy of the right lung. A leaking duodenal ulcer. Appendicitis with a high appendix. Retrocecal appendix. Note that if the gallbladder is low, the pain will be in the right lower quadrant. If the patient has situs inversus totalis, the pain will be in the left upper quadrant. Here is the deal. Differential diagnosis of cholecystitis, the extended version. Biliary, hepatic, pancreatic, gastric, pulmonary, renal, and others. Biliary, neoplasm, stricture, dysfunction of the sphincter of Oddii, especially if the patient overdosed on a morphine or a morphine fella, like heroin, oxycodone, fentanyl, sufentanil, etc. Hepatic causes, hepatitis, liver abscess, trauma, or hepatocellular carcinoma, formerly known as hepatoma. Hepatoma is not benign, hepatoma is malignant. Pancreatic problems, pancreatitis or pancreatic cancer. Gastric problems, peptic ulcer disease, because remember, cholecystitis pain can start in the epigastric region. Cancer of the stomach, gastritis, hiatal hernia. Pulmonary problems, pleurisy on the right side, pneumonia on the right side, pulmonary infarction on the right side. Renal problems, kidney stones, pyelonephritis, which is inflammation infection, and kidney cancer. Others, be careful. Ruptured ectopic pregnancy can lead to pain in the right upper quadrant. And that's why you will need to order a beta HCG to rule out the possibility of ectopic pregnancy. Shingles. Remember the herpes zoster virus that follows a single unilateral dermatome? Yeah, if the dermatome is in the upper abdomen, the upper right quadrant, the pain will be very similar. Will I see the rash? Maybe yes, maybe not. And then this disease, I'm not even going to pronounce it because it's probably a cuss word in a certain language. Fitzhugh-Curtis syndrome. Subphrenic abscess, inferior wall MI. Yeah, because it's on the diaphragm. Retrocecal appendicitis because it's a high appendix. There is no single physical exam finding that can give you a diagnosis of cholecystitis or exclude the diagnosis for that matter. Moreover, there is no single lab result capable of confirming the diagnosis, and that's why you need an ultrasound to see the stone. Diagnosis of cholecystitis. You need history, physical exam, labs, and imaging. History, fat, fertile female in her 40s. Physical exam, right upper quadrant pain, fever, Murphy sign, etc. Let's go to the labs. Quick review. ALT and AST are for the liver. ALP and GGT are for the biliary system, especially the hepatic duct and the common bile duct, not necessarily for the gallbladder. In other words, if the patient has cholecystitis, these two will be normal or at least mildly elevated. But if they are extremely elevated, think of choledocholithiasis or ascending cholangitis. Amylase and lipase are for the pancreas. Therefore, if I have cholecystitis, usually amylase and lipase should be normal. Sometimes amylase might be mildly elevated. But if they are extremely elevated, think of acute pancreatitis. Labs. Remember bacterial overgrowth, right? Bacteria. So you will see neutrophilic leukocytosis. ALT and AST, normal or mildly elevated. Alkaline phosphatase, normal or mildly elevated. If significant, think choledocholithiasis or ascending cholangitis. Amylase, normal or mildly elevated. If significantly elevated, think pancreatitis. Lipase is normal. Diagnosis of cholecystitis. History, physical exam, lab investigations. Let's go. White blood cell with differential, neutrophilic leukocytosis. LFTs, AST and ALT, normal or mildly elevated. Alkaline phosphatase, normal or mildly elevated. Amylase and lipase, normal. Sometimes amylase is mildly elevated, but if both are extremely elevated, think pancreatitis. Total bilirubin and direct bilirubin, usually normal. What if I have hyperbilirubinemia? Then the stone has left the cystic duct and is now in the common bile duct or hepatic duct. Beta HCG, why? To rule out ruptured ectopic pregnancy. After the labs, what do we do? Imaging. Who's the goat of imaging? Ultrasound, if you're talking about cholecystitis. Cholecystitis, ultrasound. Don't forget this. What should I see on ultrasound in cases of cholecystitis? A beautiful triad. You will see the stone in the cystic duct, okay? Thickening of the gallbladder wall, all right? Pericholecystic fluid around the cholecyst because of the inflammation. History, physical exam, and lab investigations, all of them point to cholecystitis, but the ultrasound was not conclusive. What should I do? Go to the next step. Nuclear scan, aka HIDA scan, which is also known as cholecystography. My goodness. What do we do? Basically, you inject a radioactive material into the patient's vein. Eventually, it will end up in the liver because the liver would like to metabolize this radioactive trace. After the liver metabolizes, it will dump it in the biliary tree. Some of that trace will go to the gallbladder, some of that trace will go to the duodenum, and then to the stool. If the trace is not going to the gallbladder, well, there is an obstruction here in the cystic duct. That's cholecystitis. What if the trace material is not reaching the duodenum? Then the obstruction is here in the common bile duct. This is choledocholithiasis. For cholecystitis, that's about it. But what if it's choledocholithiasis or ascending cholangitis? Then it's time for ERCP, MRCP, etc. Should I do an X-ray of the abdomen? No, because most of the stones are radiolucent, not radioopaque. They will not appear on X-ray. Should I do CT scan? Only if you suspect a disaster, like perforation, peritonitis, pancreatitis, cancer. For these, CT scan is doozy. What if the symptoms are so bad, yet the imagings are inconclusive or equivocal? It's time for intraoperative cholangiography. Get the lovely surgeon, get the freaking interventional radiologist. It's time to go to work. Pros and cons of the imaging modalities. Ultrasound is the gold standard for cholecystitis, very, very accurate when it comes to the gallbladder. However, it's not so good if the stone is in the common bile duct. Ultrasound gives you no exposure to radiation. It detects sludge and pericholecystic fluid. It can actually measure the gallbladder wall thickness. Let's talk about X-ray. Pros, it can detect radioopaque stones. Cons, most of the stones are radiolucent, not radioopaque. 80% are radiolucent, invisible on X-ray. Also with X-ray, there is some radiation exposure. HIDA scan. Pros, it tells you if the obstruction is in the cystic duct or in the common bile duct. How do I know that the obstruction is in the cystic duct? The tracer is leaving the liver but not entering the gallbladder. Okay. How do I know that the obstruction is in the common bile duct? The tracer is leaving the liver but not reaching the duodenum. Last, abdominal CT. Pros, it detects abscesses, cancers, pancreatitis. Cons, too much radiation. A beautiful algorithm to diagnose and manage cholecystitis. A patient came to you with right upper quadrant pain, low-grade fever without jaundice. Risk factors are classic: fat, fertile female in her 40s with fever. Then you do the labs, okay? Don't forget the beta HCG to rule out ectopic pregnancy. Even if this is not ectopic pregnancy, if she is pregnant, we will be very careful before giving her certain antibiotics. And of course, the surgeon needs to know if she's pregnant or not. I did all of these labs and now I'm convinced that this is cholecystitis. Then you should do an ultrasound. The ultrasound showed a stone in the cystic duct, thickening of the gallbladder wall, and pericholecystic fluid. You have your diagnosis, acute cholecystitis. Boom, that's it. Now you should manage it. How do I manage it? Admit the patient to the hospital, IV fluids, nothing per os, NPO. The patient should not eat or drink anything because we would like to rest the gut and rest the gallbladder. NG tube for suction, especially if the patient is vomiting. Intravenous antibiotics and observe for 24 hours. If the symptoms improved, elective cholecystectomy somewhere in the next 6 months, if the patient wants to remove it. Symptoms persisted, it's time for urgent cholecystectomy within the next 24 hours. I did the ultrasound, but I didn't see anything. It's time for a HIDA scan. If it's normal, consider an alternative diagnosis. This is not cholecystitis. If it's abnormal, biliary dyskinesia. The gallbladder is not contracting properly. What should I do? Elective cholecystectomy. Ultrasound is showing a stone, but the stone is in the common bile duct. This is choledocholithiasis. Do an ERCP with elective or urgent cholecystectomy. When should I look and explore the common bile duct, whether by imaging or surgically? If there is jaundice, if there is absence of stones, if there is acute pancreatitis, if there is common bile duct dilation that's greater than 12 millimeters. Let's manage it, baby. Management of cholecystitis, supportive care, and cholecystic. Medical management, surgical management. Let's go. Medical management. NPO, nasogastric suction. IV, hydration, IV fluids. IV, analgesics, IV, antibiotics. Analgesics like NSAIDs such as ketorolac. Antibiotics to cover what? Remember, it was E. coli, enterococci, B. fragilis, Clostridium species, so we need to cover the gram-negatives and the anaerobes. For the anaerobes, gives metronidazole because we are below the diaphragm. For gram-negatives, gives ceftriaxone. Also, piptazo has wide spectrum coverage. Next, the surgeon, cholecystectomy. We have the classical incision, or better, laparoscopically. ERCP with sphincterotomy is also an option. What if the patient is at a very high surgical risk and I would not do surgery? Example, he's very old, a calculus cholecystitis, he's in the ICU, he's in the burn unit, trauma patient, respiratory failure. What should I do? Percutaneous cholecystectomy. This required a very skilled surgeon. Prognosis: 85% of cases of cholecystitis were resolved in 2 to 3 days, even with no treatment. But 10% can suffer complications. Speaking of complications of cholecystitis, we can have inflammation, obstruction, perforation. It can go places. It can increase risk of cancer. You can have gangrenous cholecystitis, emphysematous cholecystitis, gas-producing bacteria, empyema of the gallbladder, which means collection of pus in a cavity. What cavity? The gallbladder sac. Acute cholecystitis can become chronic cholecystitis. It can perforate, causing peritonitis. It can cause a fistula, cholecystoenteric, gallstone pancreatitis, or gallstone ileus. What is Meritzi syndrome? Meritzi syndrome is the stone that's impacted in the cystic duct, starting to go crazy. Compress and obstruct the common bile duct. While still in the cystic? Yeah, while still in the cystic. It's just pressing on the surrounding structure. And in this scenario, bilirubin will not be able to flow from the liver to the gut. You will get cholestasis with obstructive jaundice, post-hepatic jaundice. Gallstone ileus was discussed in a previous video titled Gallstone ileus. Pause and review. Some pearls for the pros. 25% of elderly people have gallstones. Elderly patients with cholecystitis can have atypical symptoms, not your good old fever, right upper quadrant pain, positive Murphy sign. It could be very vague, like anorexia, confusion, absence of pain. Many patients with Dupuytren contraction have cholecystitis as well. Elderly people with cholecystitis are more likely to have complications such as empyema, perforation, fistula, and ileus. Most gallstones are radiolucent. If they contain calcium carbonate, they are radiopaque. Radiopaque calcium carbonate. Here is a summary of cholecystitis. Pause and review. To learn more about metronidazole, ceftriaxone, piperacillin, and tazobactam, check out my antibiotics course on my website, medicosisperfectionalis.com. I also have an utacois pharmacology course to teach you about medications for peptic ulcer disease, cyclic AMP, serotonin, histamines, etc. And for the next 51 students, I have a promo code KIDNEY to give you a 40% discount. This video wouldn't have been possible if it hadn't been for Grace. So please be graceful and thank her in the comments. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Thank you for watching. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.